Okay, welcome, April 8th. Got a lot of questions. Thank you for sending them over, everyone. Over to Simon.
Uh, okay, so first question is on the lateral ceph for the FN tracing. It is 4 centimeters touching the frontal bone, or simply 4 centimeters up from nasion without bone contact. So you just take a ruler from nasion up onto the frontal bone and 4 centimeters. And the point that is a straight line between nasion to the frontal bone at 4 centimeters. That's the F line to N line. So we're touching the frontal bone, yes. It's not straight up. It's F point is the frontal bone contact 4 centimeters above. So yes, touching frontal bone. Okay, next question. There is some degree of tipping of the upper molars when using bioblock, even with the resting class, this seems to occur. Does this mean you overcorrect expansion to a degree to allow later tipping from natural soft tissue functional forces? So theoretically, if we do semi-rapid expansion in the upper appliance, we should get sutural expansion with no dental alveolar involvement. The new hypothesis is that if you expand at approximately 1 millimeter a week, this will give you the exact amount of development not to have tipping, not to split the suture, but instead creates a perfect development. So John Mew stated it was 1 millimeter every 8 days. So 8 days, 1 millimeter. The reality is at the moment, there's no screws on the market that will open up 1 millimeter in 8 days. All the screws are either 0.8 millimeters or 0.9 millimeter screws. So none of them are 1 millimeter screws. So there's a slight underdevelopment, so it's a little bit slower than semi-rapid. We also run into scenarios where parents doing the activations don't actually follow the protocol, so there's variability in the rate of expansion. In addition, sometimes the appliances don't actually fit that well, and they continue to expand, so you get a sliding of the appliance incisally, and so you get a less contact with the palate, more contact with the teeth, so it becomes more likely to tip. Sometimes the appliances are made with acrylic around the first molars instead of free space and only the rest touching. And that can sometimes not allow the rests to control palatal root torque. A part of the understanding that John has for the development is that the rests are there to be activated on a regular basis to apply palatal root torque. So not every clinician will activate the rest. So all these variables create a less than perfect scenario. In addition, biologically, everyone is slightly different. John's experience was if you did 1 millimeter of expansion every 8 days, you would get that perfect development, but some children are younger, some children are older. When we do the treatment, some bone is more dense, some bone is less dense, depending on the elevator muscle tone. So there's so many little variables that creates a scenario where sometimes you get a perfect development with no tipping of the molars, other times you get a lot of molar tipping. The allowance with the rests provides the clinician the capacity to torque the roots to control that tipping force and induce palatal root torque. Encouraging the children to chew also improves root torque. So that's all part of that process of realizing that we're just talking in terms of generality, and the clinician has to be mindful of the dynamic variables and make the appropriate allowances. That said, towards the end of treatment, if you have cusp to fossa relationships in the occlusal sucking in, chewing will upright molar teeth by driving root torque in. Okay, and then sometimes you have to retract the molars in with approximating wires to tidy up excessive tipping. So they're all the variables. Next question, my experience examining cone beam CT after maxillary expansion of the bioblock reveals parallel maxillary suture opening. This would imply that the pterygium maxillary suture complex is disarticulating, which to me means that subsequent forward growth remodeling of the entire maxillary is enhanced, provided that rest oral posture is established. Do you agree with this hypothesis? Yeah, it was John Muir's hypothesis that if you develop the maxilla in a semi-rapid expansion phase, the what he called salts within all the sutures would dissolve, and the whole maxillary complex would not only develop in the transverse, but the structures that are interconnected with the skull also loosen and free up. And if your posture is correct, with the closed mouth, driving a counterclockwise rotation, then the maxilla will come forward while it is expanded. So do I see this in clinical practice? It appears to be so. So, that's the premise that we're working on with the semi-rapid expansion in the preparatory phase and using the stage 3 and 4 appliances to strengthen good oral posture will drive the maxillary complex in counterclockwise and forward rotation. So in addition to improving chin position, we also get advancement of the maxillary complex. How long do you hold in retainers after expansion? As I'm wondering, I don't want to interfere with further jaw growth. I'm thinking that after a year, I would like to move to my functional orthodontic appliances board at night. What do you think about this? A lot of it depends on where you are with uh, what you have finished at the end of your expansion. So, how old are we when we finish expansion? What was the deficiency to begin with? Where are we in growth and development? Um, the general concept is um, expansion is an artificial uh, input because the jaw complex is collapsing down and back, because the posture is poor, because the mouth is open too much. So either lips are not in contact, teeth are not in contact, tongue is not on the palate and the floor simultaneously, or any variation or combination. Development of expansion corrects the transverse component, and theoretically, if we can correct the posture after our arch development, then you don't have to retain it at all. But the reality is, just making it bigger doesn't mean they know what to do with it. So you have to train the children to improve their posture. While you're training them to improve their posture after you've done your arch development and your expansion, you will only be able to get correct posture if the arches are reasonably well coordinated, and if we can hold resting posture without an airway disturbance. So if you can't get good resting posture after your arch development and expansion, then it will never be stable. If you are able to achieve good resting posture, but the child doesn't learn the lesson and lapses back, then the development is unstable. So in order to have good posture, you actually have to have good orthodontic and orthopedic alignment. So the variation of components is when you finish your treatment in structural changes, have you actually provided structure that can hold good posture for you to train the child to learn good posture, and then for the child to learn good posture and to maintain good posture? Once that is achieved, you can theoretically let it all go. But when you can't achieve that, then you've got to retain for a lot longer, because they're not going to be able to self-sustain those changes. So what are the variables? Structural issues, postural issues, airway issues. So the decision is also based on, are they in transition from primary dentition to mixed dentition to permanent dentition? It's not appropriate to retain dentition positions during a transition phase. So if they're transitioning from mixed dentition to permanent dentition, you've got to close leeway in order to achieve the correct occlusal relationships. So you can't hold that space. So all these variables come into play. Right? If you finish your development and you've got years before the final changeover, then you can hold it for longer. If you finish your development and they start that rapid changeover of teeth, you have to let things go. If you're in permanent dentition when you finish, and their nose is blocked and they can't hold good posture, you might have to keep your arch form stable by night retention indefinitely, like orthodontic procedure. So lots and lots and lots of variables depending on the situation. Certainly, you can't learn perfect posture if you've got something in your mouth that blocks you from being perfect. But if you can't be perfect, then you might have to have something in your mouth to stop everything from collapsing back. Next question. For an 8.5-year-old who we are waiting for the primary first molars to fall out, and we will be distalizing the erupting 4s to make room for late erupting lower 3s. And we are waiting many months for the D's to exfoliate. At what point would we have the child wear the plants at night only while we're waiting, assuming we are no longer actively expanding? So in the lower arch, normally we have transition of mixed dentition to permanent dentition at around 10 years of age. At 8.5, theoretically, we have our incisors in place, the permanent incisors. We have the primary canines, the primary first and second molars, and the permanent first molar. At around 10 years of age, our C's should exfoliate for the permanent canines to come through. Then at around 10.5 or 11, our first premolars will come through the D's. And then at around 11.5, the E's will fall out and the second permanent molars will come through. And then leeway will close as the 6s drift forward, as the 12-year-old molars come through at the back. So that's the normal sequence of events. Now, if you have a situation where the first premolar erupts ahead of the permanent canine, then you run a risk that you will not have sufficient space for the permanent canines to fit through, because the first premolar will drift forwards and eat up the leeway space. If that's the case, and you have a late or blocked out lower canine, then you have to actually actively hold that premolar until it socks in with the opposing premolar. Until it's socked in, it will drift forwards. Mesial drift is real. So you have to actively hold that in place when it's erupting full time. When it's socked in, then you can move to nighttime only retention, because it won't come forward because it's interdigitating with the opposing premolar, assuming that your posture is strong enough that they're resting with their teeth together. If they're resting with their teeth apart, if you're not actively controlling an erupting tooth, it will drift in and close up leeway by the process of mesial drift, and it will block out the permanent canine. Okay. If you have to distalize it in addition, because often the primary canine is lost because of anterior crowding and the permanent lateral eats through the C space, then again, you have to actively, permanently hold the 4 from eating up the 3 space, and you have to hold the 2 from drifting distally until the 3 makes its way through, until the permanent canine makes its way. So space maintenance is kind of a full-time activity. Next question. I sent a previous question about the same topic, but wanted to ask it a different way. What points during treatment do you have patients only wear their passive expanders, retainers at night? They're still in active treatment phase, but not turning appliances because in a holding pattern. They haven't masked Go-Fx because they haven't done with tooth changeover. So can they cut back on nighttime wear mid-treatment when waiting for, let's say, bud customers to arrive? So what holds an arch form is posture or an artificial appliance. So if a posture is correct, then the teeth are self-retaining, the arch form is self-retaining. If posture is not correct, then artificially developing arch forms will collapse overnight, right? Because the teeth and the arch will move towards the neutral position or neutral zone, which is determined by the resting posture. So if we have developed our arch well and we are reasonably coordinated with our bite and we have good structural balance, when we have learned how to control that space with the Go-Fx training, and we can demonstrate that we are resting with our tongue to the palate with good suction and a closed mouth resting posture, at that point, you can move to nighttime only retention. But if you haven't mastered Go-Fx and shown there to be strong resting posture, then if you take the plates out, they'll stop fitting after a few hours. Because the arch will want to return to suit the neutral zone, which is whatever the resting posture is. Your arch development to kind of like an ideal form is based on the assumption that you're going to utilize that space with good resting posture. If you utilize that space with the original poor resting posture, then the arch development is unsustainable unless it's held artificially. Next question. From your course, I understand that one of the differences between Class 2, Division 1 and 2 is the muscle tone and lip seal. In Class 2, Division 2, which has high muscle tone, how do we address this issue with appliances and exercises? So, Class 2 relationships are a situation where sagittally the maxillary is ahead of the mandible. The fundamental difference between the two is that it's presented with bucky front teeth in Division 1 and retroclined front teeth in Division 2. The display of this relationship is based on the fact that Division 1, Class 2 children rest with their mouths completely open or bite on their bottom lip. Rest. Division 2 children rest with their lips tightly together, but the teeth are always apart with the tongue between the molars. One has a higher muscle tone than the other because one is actively fighting gravity. That's Division 2. Whereas the other, which is Division 1, is letting gravity completely win. None of them, unlike Class 1 relationships, use the negative pressure of suction hold to combat gravitational pull. So what's the difference in appliances and exercises? Well, we're aiming in all cases to achieve the same relationship as the optimum class 1 with the closed mouth resting posture. We want the lips together softly at rest. We want the teeth together softly at rest. We want the tongue suction to the palate. So our appliances are designed to develop the arches in a way that allows that to occur. And the exercises focus on the appropriate improvement of muscle activity and resting posture. So in the case of Division 1, where the front teeth are bucky, sometimes your appliances are designed to slightly reduce the tip effect of the upper incisors. In Division 2, where the upper incisors are retroclined, your appliance is going to be designed to tip the incisors into a better relationship. This also applies to the lower arch. In Division 2 relationships, often we have a greater curve of Wilson and Spey. We've got a deeper bite. And so sometimes the appliances get broken easily because we've got teeth clashing with wires. And as the muscle tone is higher, we're more likely to break appliances. And sometimes, occasionally, we have to look at separating like bite turbos, if you like, the occlusal forces. Sometimes we have to build a bite raising block. It's not ideal, but it depends on how high the muscle tone is and how marked the curve of Spey is. Ultimately, our goal is to improve the resting posture once we've developed the arches and the arch forms. So we have different muscle tone and muscle activities. In Division 2 children, because their muscle tone is high and their lip tone in particular is overactive, we don't need to make their tone much higher. So we don't have to focus so much on building muscle tone. We do have to focus on relaxing lip tone. Division 2 relationships primarily fail from becoming class 1 because the children are resting with their teeth apart and their tongue between the molars. So our focus is more on keeping the teeth together at rest and the tongue on the palate. In Division 1 relationships, the whole mouth is open and the muscle tone is very poor. So we've got to focus on improving muscle tone. So chewing Vopex is much more important. And then focusing on lip seal is important, but lip seal in the sense that we are trying to get the teeth together so that the lips naturally contact without excess activity. So your emphasis on the exercises slightly changes depending on whether you're resting with your mouth completely open or whether you have tight lip seal but teeth and tongue in their incorrect positions. We have less airway issues with Division 2, more airway issues with Division 1. So addressing nasal patency, clarity, airflow is very important, particularly with the Division 1 relationships. Next question. For the resting posture, Dr. Mew said the teeth are touching lightly. Some practitioners advocate resting interdental space of 1 to 2 millimeters. What's your view? So I'm in the Mew camp. I prefer to have teeth lightly touching. So hovering between 0 and half to 1 mils. All right, so that's what I advocate. Resting posture cannot be perfect if the teeth drift too far apart. You end up increasing lip tone, and you end up with a slight division 2 relationship. When you have tongue to palate vacuum seal, the teeth naturally end up very close together without masseter temporalis activity. If you don't have tongue to palate vacuum seal, then holding teeth together is an elevator muscle activity. So you end up clenching. That's not something that we advocate. So resting with the teeth together is a passive outcome of a correct swallow and a vacuum seal of tongue to palate. Artificially holding teeth together while your tongue is off the palate is an elevator muscle activity and is a functional activity, not a postural position. All right, when you hold functionally teeth together, then you're exerting elevator force, which is no longer a passive relationship, but an active relationship. This is why most people advocate for a freeway space, because of the concern of excessive active function causing damage to the structures, which is a reality. We want the teeth in passive contact. We don't want the teeth in active contact. When you understand the difference between function and posture and how correct posture allows passive contact of teeth with only favorable outcomes versus incorrect posture with active contact of teeth inducing parafunctional forces and damage to the structural system. I think until you fundamentally understand the difference between posture and function, you will never understand why we advocate a nil freeway space and why there is such a strong vocal advocacy for a freeway space. Freeway space advocates don't understand the difference between function and posture. In postural orthodontics, the intermolar width is between 38 to 42. It's getting more width to be detrimental or less width. How do we adjust expansion to get the width? Is it adjust upper non-stop to ideal or do halfway to let the lower catch up? So the ultimate intermolar width dimension relationship is determined by the size of the child. If they have normal sized teeth, normal sized tongue, then that relationship is correct. Right? If we've got very small structures, then you don't need even 38 millimeters. If you've got enormous teeth and enormous tongue, 42 might not be enough. So it's just a general guide. What I advocate is you expand until about 37 millimeters and then you assess. Do we have really big teeth? Do we have really small teeth? Do we have a real big tongue? Do we have a real small tongue? If we're getting close to 37 millimeters and the teeth are tiny and the child is tiny and the tongue is tiny, then sometimes I'll stop at 36 mils because if I've got enough room for the permanent incisors and the tongue seems to fit within the space that's present, then that's all you need. So we stop at 36, 37 mils. When we get to 36, 37 mils, and it's clear that it's nowhere near the space you need, then you can keep expanding to 38, 39 mils. If you're not 100% sure, then we stop at 36, 37 and we wait for the lower to finish flattening of the curve of Wilson. And then we assess, are we able to continue our upper expansion because we still have room to develop the lower arch? Or is the lower arch starting to tip adversely? And what we actually need is improvement of sagittal position, right? In which case, you can't expand your way out of a sagittal problem, right? So that's basically how I will treat the child. We make a judgment call about the size of the teeth. We stop our expansion at around 36, 37 mils, and we assess where we are with the lower arch, with the upper arch teeth and the size of the tongue. Well, we keep going. If we've got really big structures, we stop and let the lower express as closely as we can. And then if you've developed a lower arch and it's looking really nice, and then you realize, oh, the upper is now edge to edge, then you know, oh, I can expand the upper until we hit 38, 39, or 40. So we get to a reasonable minimum level, 36, 37 mils. We stop. Unless it's clear we've got plenty of arch development potential in the lower, and we've got crowding there, and we've got really big teeth on top. Then we just keep going until 38, 39, and then we stop. And then we let the lower catch up, and then we make a judgment once we get to the mean ideal to see if we have to go higher to allow for the individual variables. Okay, so that's our exciting adventure for today.
Perfect. Looks like yeah, no one else had any other questions I asked in the chat.
All right, some good questions today.
All right. Thanks, Simon.
Fantastic.